Welcome back to my channel Medico's Guide. I'm Dr. Rida Khan, and in this video I'm going to talk about the assessment of musculoskeletal system. In the previous video we have discussed about the structure and also we have seen the functions of the musculoskeletal system, and now in this video we are going to be discussing about the assessment of musculoskeletal system in a great detail. So let's get into it. So first of all, the basic screening involves inspection. Here in the inspection, we look for the joint symmetry, any deformity, the skin color changes. For example, if the skin is red, so it will show us that the inflammation is present there. Then we also look for the tenderness, any kind of infection. So here these are the things that come in inspection. Now in the palpation, what we palpate the skin to look for the changes in the skin temperature, to look for the local tenderness, or to observe any kind of swelling there or the crepitations. So these are observed in the palpation. Now in the range of motion, so the range of motion is checked so that we can find out any kind of restriction in the range of motion and what's the cause of it. Now the muscular strength, so the muscular strength which is tested by the MMT. So here we check for the muscle strength so that we can find out if there is any weakness in the muscle, if there is atrophy or any other abnormality. Now the musculoskeletal examination is divided into three. So it's basically divided on the basis of the region we are assessing. So if we are assessing the spine, so this would be known as a spinal examination. Then for the upper extremity we have a different examination. Then for the lower extremities we have a different examination. So this is how we divide it. Now what comes under these components? So first of all, in the spinal assessment we basically evaluate the musculoskeletal structures of the spine, that are the vertebra, discs, soft tissues. And here what we are observing for the range of motion of the spine, any abnormality in the spine, any abnormal curvature or any deformity, and the functions of the muscle that are supporting the spine. So these are all the things that we do in the spinal examination or the spinal assessment. Now in the upper extremity examination, what we do, so basically we evaluate the musculoskeletal structures of the arm, of the shoulder, of the hand, and we basically observe here for the joint mobility, muscle strength, coordination, deformity, any swelling or nerve compression. And the same observation goes with the lower extremity assessment. But there are some additional things. As you know, we can also observe for the gait assessment, gait abnormality in the lower extremity. We also observe for any issues with the weight bearing structures in the lower extremity. So these are all the things that we do in the spinal or in the musculoskeletal examination. Now as you know that there are some special maneuvers which are known as the provocative test, and basically these are done to rule in or rule out whether the patient has some certain musculoskeletal condition. For example, if the patient has sustained the ACL tear, so we are going to perform the anterior draw test for that. Or if the patient has the CTS, so we will perform the Ferrin test or different test for the different conditions. Now let's talk about the components of the musculoskeletal examination. So here we have different things. So we are going to discuss about all of these components in a great detail ahead. So let's just name these components here. So the different components are the patient history, pain, observation, posture, limb position, skin integrity, palpation. We have upper and lower quarter screens, functional mobility and safety, diagnostic tests, and the management. Now let's discuss one by one. So first of all, we have the patient's history, and here the first thing whenever the patient comes to us is the question, that is what's the cause and what's the mechanism of injury. So basically this type of question is asked in order to diagnose the condition and select the appropriate treatment for that condition. As well as this type of question would help us to determine that whether the condition is acute, if it is chronic, or if it is because of some repetitive stress. Then the second question is previous musculoskeletal, rheumatologic, neurologic disease, injury, surgery. So basically what we are asking here, we are asking about the patient's past medical history. So past medical history, as you know, is very important. It can influence the recovery process of the current medical condition, or it can also predispose the person to a new condition. That's why this type of question is asked. Then the third question that is asked is the functional level before admission. So basically the functional level of the patient that was before the admission. So this is asked so that we can set this functional level as a baseline for setting a realistic rehabilitation goals. As well as this would tell us about the impact of MSD on patients' daily life and independence. Now the previous use of assistive devices. So basically, this would help us to determine or this would guide us in the selection of a new devices or the adjustments. And also, this would tell us about the patient's familiarity or the comfort with the assistive technology. Then recreation or the exercise level and frequency. Okay, so as you know that the regular activities they can affect the health and our ability to heal. That's why this is asked so that we can determine what is the lifestyle of a patient and whether it is needed to be modified or not. Then we have the need for adaptive equipment or the footwear on a regular basis, for example, the shoe lift. So basically, this is asked so that because you know that the adaptive equipments and the footwear they are used to compensate for the functional deficits and the further injury. That's why so that we can assess the need of the patient for these type of equipments, so we should ask this question. As well as this may indicate the severity of the MSD and what is the patient's long term needs, so this type of question is asked. Now the history of falls. So history of falls can signal any balance issues, weakness or other risk factors. So this is very crucial if the patient has positive fall history. So it's important for us to design a fall prevention strategy for the patient and ensure patient safety. The next thing is history of chronic pain. And as you know that the chronic pain affects the quality of life and response to treatment, that's why it's very important for us to manage the pain, and this may also require multidisciplinary approach sometimes. Now the physician dictated precautions and the contraindications to treatment. So you know that it's very important for us that the physician dictated precautions and contraindications they are adhered so that we can avoid any complication or the worsening of the condition. And this can also guide us in the rehabilitation process and ensure patient safety. The need for a splint and brace, and as you know that splints, braces, all of these they provide support, stability and pain relief. That's why determining the need of them is essential for protection and aid in recovery. Now most recent lab values. So basically these are very important in order to look for any abnormality in the blood parameters, be it a raised DSR, so this is indicative of inflammation, or it can be an abnormal CBC which can be presented in the form of raised white blood cells. So this is how it would help, and as well as it would identify any kind of systemic issues that can contribute to the MSD. Now type and last dose of the pain medication. So this would tell us about the current pain management strategy that is used by the patient as well as the effectiveness of them. And if for example these are not effective for the patient, so it's important for you to design a new treatment plan for that patient according to the severity of the pain. Now whether the patient has been out of bed since admission to hospital, so this is important in order to identify what is the impact of MSD on patient's life, the progression of it, complications of them. Also this would help us in the planning the rehabilitation process as well as the physiotherapy intervention that is used for the patient. Now comes the observation. So in observation, first of all, we look for the general appearance of the patient, and here we are looking for overall physical condition of the patient and demeanor of the patient, that is the behavior of the patient. And here we are observing for any kind of deformity, abnormal posture or visible discomfort. Now the level of alertness, anxiety and stress. So this is to measure the emotional and the mental state of the patient, because you know that this state can also impact the patient's MSK symptoms. Then the willingness to move and muscle guarding. So here we have to observe that whether the patient is hesitant to move due to pain or any muscle guarding. Then presence of external orthopedic devices. So this is to identify any external aid or devices that might influence the patient's mobility and musculoskeletal conditions. Now the muscle substitution on active movement. So as you know that muscle substitutions are basically the compensatory movements. So this would indicate us that whether there is any weakness or dysfunction. And for example, if the patient has a weak hip abductor, so the patient would tend to use his lateral trunk muscles or the tensor fasciae lata. Or if the patient has, for example, weak shoulder abductors, so the patient would tend to use his scapular stabilizers in order to initiate the movement. Now in the posture. So in the posture, it is very important that we observe the patient's posture in every position. It means that in the supine position, in sitting position, in the standing position, so that we can identify any variations or abnormalities. And here we have to observe that how the patient holds their body in the different position. For example, basically it means that we are looking for the weight distribution by the patient. Then the area of the strain that can be because of any muscle imbalances, or we are also looking for any kind of deviation. And here in basically the posture, we are inspecting the posture of the head, posture of the trunk and extremities, and here we are looking for the alignment, symmetry, deformity, atrophy in any of these. Now let's talk about the postural assessment. So on the left extreme, you are looking that this is a good posture, while all the other postures on the right side they are abnormal. So you can compare them with the good posture in order to identify any abnormalities. So now on the right extreme, first of all we have a sway back. So what are the characteristics of the sway back? In the sway back, the entire pelvic segment is shifts anteriorly, and this results in the hip extension. Then there is posterior shifting of the thoracic segment, and that results in the flexion of the thorax. And this posture is also associated with the lordosis, kyphosis, and the forward head. Next posture is the lordotic posture, and in the lordotic posture there is increase in the lumbosacral angle, there is increased lumbolordosis, there is increase in the anterior pelvic tilt, and that's why it results in increase in the hip flexion. Now in the thoracic kyphosis, and the thoracic kyphosis is also known as round back. Here basically there is increased thoracic curve and there are protected scapulae that are known as round shoulders. Now the forward head. In the forward head, there is protraction of the head, and basically there is increased extension on the upper cervical vertebra, while there is increased flexion on the lower cervical vertebra and upper thoracic vertebra. And this posture is also associated with TMJ dysfunctions. Now limb position. So in the limb position, we observe for the resting limb position, and here we identify, we note any kind of deviation in the joint angles in the alignment. Then comparison. So we compare the limb to the normal anatomic position. Here when we are comparing it with the normal anatomic position, we identify any differences in the alignment, in rotation, in the symmetry compared to what is expected in the standard anatomical position. Then comparison to the contralateral side. So when we are comparing it with the contralateral side, we assess for any asymmetry or any discrepancy. Then it is also very important for us to note that whether the limb is naturally positioned or if it is supported. Discoloration, bruising, scars. So let's first discuss them. So let's first start with edema. And edema, as you know, it means swelling. And if there is swelling, so this would indicate the presence of any inflammation or the fluid accumulation. And if the edema is present, you have to note what is the extent of edema, what is the location of it. You have to note the symmetry and the changes that are taking place in edema over time. Now discoloration. So discoloration means the changes in a skin color, and this would signal the vascular or tissue damage. And if the discoloration is present, you have to note what is the type of discoloration it is. So if it is a redness, if it is paler, if it is cyanosis, and each color would tell us about different condition. Now if the discoloration is present, so you have to document the distribution of the discoloration, what is the intensity of it. Now let's talk about the bruise. So bruising would tell us about the bleeding under the skin. Okay, so this is basically a sign of bleeding under the skin, and this would indicate any trauma or injury. And if the bruising is present, you have to note, you have to document the presence, the size of it, and the color of it. Now the scar. So in the scar, we inspect the skin, we inspect for the changes that are occurring in the existing scar and for the healing in the new scar. And if the scars are present, so you have to observe the size of it, color of it, and the texture of the scars. And yes, you also have to observe that if there are any signs of hypertrophic scarring or the keloids. Now, traumatic injury inspection. So, here we have to examine the skin for any kind of traumatic signs. You have to look for lacerations, abrasions, or any other sign of injury. And here we also have to note the severity of it and the extent of the traumatic injury. We inspect the incisions of the recent surgeries for the healing progress. We also have to document the location, direction, and the quality of incision. Then we have to assess any signs of infection, dehiscence, or the delayed healing in the surgical incisions. Now, the pressure source. So, in the pressure source, we have to identify the areas that are prone to the development of the pressure source, and the signs can be redness, warmth, or the breakdown of the skin in that area. And we also have to note the existing pressure injuries. Now let's talk about the palpation. So in the palpation, first is the skin temperature. So we have to note down any temperature variation in the skin that is at the injury or around the injury site. So here in the temperature variation, if there is any warmth or coldness, so this would show us the changes in the blood flow or inflammation. Now the capillary refill. So capillary refill gives us the insight into the peripheral circulation, and here we have to check that how quickly the blood returns to that area if the after the pressure is applied, and the normal is less than 2 seconds. Now the peripheral pulses. So here we have to examine the presence, strength, and the symmetry of the peripheral pulses, and we have to evaluate any differences in the strength or the absence of the pulses. This would indicate the vascular compromise. Now comes the upper and the lower quarter screens. So here, upper and the lower quarter screens involve three things. We have the dermatome, myotome, and the reflexes. So first, the dermatomes, they are used to assess the sensory nerve function. So here we have to identify any altered sensation, for example, numbness, tingling, or the heightened sensitivity. Then in the myotomes, these are evaluated to assess the muscle strength associated with a specific nerve root. So here we are looking for any kind of weakness, atrophy, difficulty in the muscle activation. Now the reflexes are checked for looking for the integrity of the nervous system. So here we look for any kind of abnormality like the hyperactive reflexes or the diminished reflexes. So this would indicate nerve or the spinal cord involvement. Now we have the functional mobility and safety. So the functional mobility includes bed mobility, transfers, ambulation, medical surgical stability and the prior functional level, and other things as well. So now let's discuss them one by one. So first, in the bed mobility, here we are looking for the patient's ability to move in bed, and here we are observing if there are any challenges, limitations in rolling, turning, or changing positions while lying down. Then in transfers, we are assessing the patient's ability to move in different positions or to switch between different positions, for example, from sitting to standing or so on. And here, basically, we are observing for any kind of difficulty, compensatory movements, or need for assistance. Now, the ambulation of the level surfaces in stairs. So, here we are looking for the ability of the patient to walk on the flat surfaces and ascending descending stairs. So here we can observe for any kind of abnormality in the gait, any balance issue, or any challenges faced by the patients. Then the medical surgical stability and the prior functional level. So here this would tell us that how the MSD has impacted their current functional status compared to their prior level of the activity. Now safety is very important. It's a key component of function. So this is very important that the safety is ensured, and here in the safety we are basically looking for that the patient, is he able to bear his weight, can he use supportive devices correctly, then whether he is able to maintain safety during mobility, then if he is if he is conscious about his risk of falls, and if he can adjust the speed of movement, if he can recognize the onset of fatigue or maintain the body mechanics. So these are all the things. Now let's discuss a brief about diagnostic tests that are used to examine the musculoskeletal disorders. So there are few tests that are performed, and these are the radiography, computer tomography, magnetic resonance imaging, bone scan, arthrography, myelography. So now let's discuss them a little bit. So first of all, we have a bone scan, and the bone scan is very important to detect any metastasis, especially if it is in the skull or in the sternum, in the scapula, or the anterior ribs. And there are some other indications as well. So the bone scans can also be used to diagnose the stress fractures and other non-displaced fractures, early osteomyelitis, inflammatory or degenerative arthritis, AVN, which is avascular necrosis, or the myositis ossificans. And here are the images. Now the arthrography. So arthrography, wherever the word graphy would come, so this would indicate the radiograph, which is the X-rays. And here, basically, the arthrography, as the name is telling you, that it is a radiograph of a joint, and it is done with the air or the dye contrast. Then this is primarily performed on the knee joint, on the shoulder joint, on the hip joint, and here we can examine for any kind of internal derangements that are occurring within the joint or any kind of soft tissue disruption. Then this can also be used to diagnose the meniscal or the cruciate ligament tear, articular cartilage abnormalities of the knee, adhesive capsulitis, which is also known as frozen shoulder, then rotator cuff tears of the shoulder, arthritis, intra-articular neoplasms of the hip. So yes, it can be used for diagnosing many of the disorders of the joints. And here is the image. Then we have a myelography. Now in the myelography, it is basically a procedure that is performed for the spinal cord, for the nerve root, or the dura mater with the dye contrast. And now basically this is utilized in order to detect any spinal stenosis, cord compression, intervertebral disc rupture, or the nerve root injury. And here is the image that is telling you how the myelography is done. Okay guys, so that's it from my side from today's video. In the next upcoming video, we are going to be discussing about the pathology of the musculoskeletal system in a great detail. And yes, that's not over. I'm going to leave you a few questions. And these are structures involved in the active passive shock absorption, normal time of capillary refill, characteristic of the sway bag, and I want you to please comment down below the correct answers of them so that I can cross check. And I really appreciate your response, and I love reading your comments. And if you have any topic in your mind that you want me to make video on, so please let me know in the comment box below. And also, if you enjoyed this video, don't forget to hit the subscribe button and like button, because it really motivates me to make more videos. And thanks for watching. Stay tuned for the upcoming video and take care of yourself. Bye.